Good evening, everyone. Welcome to this NEET PG video based question series in dermatology. I'm Dr. Jazeer, your dermatology faculty at PW Meded. So, can you please confirm in the chat box if I'm audible and visible? If you could confirm about the audio and video, I shall get our session started for now. Yeah. So, let's start with the first question of the day. The first question is a 28-year-old man presents with recurrent episodes of the lesions as shown in the video. He has no fever or mucosal involvement. Which of the following features would most strongly suggest an alternate diagnosis rather than the ordinary urticaria? So here there's a mention that rather than ordinary urticaria, what is going to suggest an alternative diagnosis? Now let us also see this video first. To see the video, one moment. So this is the video that we are discussing in this. You can see that there the patient has developed multiple urticarial wheals, right? So over both the thighs there are multiple urticarial wheals, and these wheals are usually going to be itchy as well. Now this looks like a classical case of a urticaria, right? It looks like a classical case of a urticaria. There is some lesion in the forearm, there is some lesion over the thighs as well, and these lesions are usually going to be itchy, and we know that the diagnosis is going to be urticaria. Now coming back to the question. The question says this is a 28-year-old man with a recurrent episode of such lesions. There is no fever, there is no mucosal involvement. Which features suggest an alternate diagnosis? Now can you see the options now? Alternate diagnosis कौन सा होना चाहिए? जैसे intense pruritus with transient wheals lasting for less than 24 hours. Individual lesions persisting for more than 24 hours with some residual purpura. Dermographism elicited by stroking the skin. Angioedema involving the lips without skin discoloration. How many of you can give me the right answer in the chat box? Can you please let me know what should be the right answer here? The clue is, see, please make sure that you understand the question well. Now the question is asking you, if this should not be ordinary urticaria, what should be the odd one out, right? So let's see one by one. Intense pruritus with transient wheals lasting for less than 24 hours. What is this? This is definitely a feature of urticaria, right? क्योंकि pruritus होगा, pruritus means itching. Along with itching, the patient, these wheals will be lasting for less than 24 hours. Now see the second option. Individual lesions persisting for more than 24 hours with a residual purpura. So for how long does the urticarial wheals last for? Usually the urticarial wheals, they last for less than 24 hours, right? So if it is more than 24 hours, we must be thinking something like a vasculitis, right? So this can be associated with an urticarial vasculitis. So yeah, यहाँ पे the diagnosis has already changed. But still, let's see the third option. Dermographism is elicited by stroking the skin. So if I'm going to stroke the skin like this, if the patient is going to develop red dermographism, that is going to be associated with chronic urticaria. So it's associated with chronic urticaria. That is also urticaria. The next one, angioedema involving the lips without skin discoloration. Because this is also possible, because there can be patients who are having urticaria along with angioedema as well. So what is the alternate diagnosis here? The alternate diagnosis feature should be option B, that is individual lesions persisting for more than 24 hours. If it is more than 24 hours, we don't call it as a normal urticaria anymore. It should be a urticarial vasculitis. It should be an urticarial vasculitis, right? So with your permission, now I'm going to the next question. A newborn is bought with the lesions as shown in the video. These lesions, they develop at sites of minor trauma since birth. What is the most likely diagnosis? If you want to see the image, the video is this one. You can see that there is a neonate here. The neonate has developed some bullous lesion. Can you see those bullous lesions over the extremities and all? It has not ruptured. And you can see that the child has developed multiple bullous lesions over the trunk, over the legs and all, right? Now here, what is the diagnosis most likely going to be? So are you going to think about something like pemphigus vulgaris, pemphigus foliaceus, bullous pemphigoid, especially if it is a neonate? If it's a neonate, you're not going to think any of these, right? And see, these are the bullous lesions that you can see over the extremities as well. And the MCQ is giving you a clue. What's a clue here? The lesions are developing at the sites of minor trauma since birth. Now, what is this? Is it bullous impetigo, epidermolysis bullosa, staphylococcal scalded skin syndrome, or is it going to be incontinentia pigmenti? Just give me the answer. Anybody who could answer? See, whenever you can see that a bulla is formed at the site of trauma, this is an example of a mechanobullous disease. So what's the meaning of a mechanobullous disease? For example, trauma prone sites like our extremities, when you develop bulla at the trauma prone sites, it's called as a mechanobullous disease. And mechanobullous disease, when it happens in a neonate, this is called as epidermolysis bullosa. So here the correct answer should be congenital epidermolysis bullosa. Now why the other answers are wrong? Because in case it was a bullous impetigo, in bullous impetigo, it has nothing to do with trauma, right? It can be an infection where multiple bullous lesions can be present in the child, but there is no history of trauma. How about staphylococcal scalded skin syndrome? Here, there will be a history of a staphylococcal infection, like a staphylococcal conjunctivitis or a staphylococcal impetigo or a staphylococcal furuncle. All these could be a history of a staphylococcal infection, after which the child will complain of fever along with peeling of the skin, right? After which the child will complain of fever along with peeling of the skin. All these are going to be the symptoms of staphylococcal scalded skin syndrome. Whereas what is incontinentia pigmenti? In incontinentia pigmenti, you will not see there is no bullous lesion, isn't it? So incontinentia pigmenti is a condition where the patient can develop as an X-linked dominant disease. The patient will be developing lesions along the lines of Blaschko. So here the patient will be developing lesions around the lines of Blaschko. This is called as incontinentia pigmenti. So from this video, the most appropriate answer should be epidermolysis bullosa. It should be epidermolysis bullosa. Is that clear? So now moving to the next question. A 7-year-old child is brought with the scalp lesion as shown in the video. There is mild itching and no scarring is present. What is the most likely diagnosis? Now there is a 7-year-old child. There is some lesion in the scalp, right? There is mild itching and there is no scarring. And let us see the video first. The video is this one. Now imagine that you are examining this 7-year-old child. You can see that the entire hair is now removed, and in the scalp you can see some areas of patchy scaly lesions, right? So there's a patchy lesion, some scaly lesion can be seen. And when you ask the child whether there is some itching, the mother or the child is going to answer you that yes, there is some mild itching as well. Now this is what you can see. Now when you see this in the video, now let us see what is the diagnosis going to be. Now going back to the MCQ, now here, is it a alopecia areata case, or is it a Tinea capitis, or seborrheic dermatitis, or trichotillomania? So what do you think is the right answer here? I'm just giving you some time for you to answer in the chat box. Shreyas says it is going to be Tinea capitis. How many of you agree with Shreyas? So is it Tinea capitis? Absolutely. So that is going to be the right answer here, right? Because in case the child had alopecia areata, the child would be having some patchy hair loss. And alopecia areata in a child is very less likely because it is an autoimmune disease. The common age group would be somewhere around 40 years of age, right? Tinea capitis. This Tinea capitis is going to be a very common condition that is seen in children, because Tinea capitis is most commonly seen in children. There are different types of Tinea capitis like Irion, Favus, Black Dot, Grey Patch. isn't it? But all these kinds of tinea capitis is going to be more commonly seen in children. It is more commonly seen in children, and since it is going to be itchy as well as no scarring is present, most likely it should be a tinea capitis. Now talking about seborrheic dermatitis. What is seborrheic dermatitis? It is dandruff, right? So dandruff is also a possibility here. It can be a good differential diagnosis, right? But usually dandruff, you will not end up in having these kind of patches. Now these kind of patches usually seen in tinea capitis. And what is trichotillomania? So in trichotillomania, again, the history here should be different. Like the patient is having a hair pulling disorder, right? In trichotillomania, this is a hair pulling disorder. But here the history doesn't say about any hair pulling, right? The history only says there is a mild itching, no scarry lesions in the scalp. So among all the 4 options, the best answer should be tinea capitis. Yeah, without a history, just by the picture can we diagnose? Not possible in most of the times. A history is very important, and in each of the MCQs, you can see that in each of these MCQ, there is something in the history. Like in the previous MCQ, there was a history of a minor trauma. Now, in this MCQ, there is a history of some itching and there is no scarring. So all these things you have to use to correlate to reach out to the final diagnosis. Done? So now, moving to the next one. A 38-year-old woman presents with the skin lesions as shown in the video. She has been applying a topical betamethasone for the past 3 weeks. The lesion have gradually enlarged despite treatment. What is the most likely diagnosis? Now, when you see this video, let's see the video as well. Now, this is a video. Now, this woman has come to you, and this woman is having some lesion over the neck region and the upper back, right? So all those are some plaque kind of lesions. I can see some scaling is also present, right? But this patient is telling you she applied betamethasone cream, and after applying betamethasone cream, that too for 3 weeks, the lesion is still increasing in its size. So what does it mean? Does it mean that there is some response to the treatment or there is no response to the treatment? Obviously, this means that there is no response to the treatment, right? So we should not be using betamethasone for this condition. Now, what could this condition be? That is the question here, right? So now let me go back to the MCQ. So once we go back to the MCQ, the options are nummular eczema. If it was nummular eczema, this would have been responsive to steroids, right? Because any kind of an eczema, it will be responsive to steroids. Second one, tinea corporis. Third one, tinea incognito. The fourth one is pityriasis rosea. Can you answer in the chat box what would be your answer? Is it A, B, C or D? What is the right answer here? Anyone? A, B, C or D? Yeah. So here the patient is having some skin lesion and the lesion is not improving with steroids. That is the biggest clue that you have. So here your correct answer should be a tinea incognito, because here the diagnosis initially would have been a tinea corporis, and you can see that tinea corporis is also there in one of the options. But this tinea corporis has been manipulated. It has been manipulated. How is it manipulated? It has been manipulated with steroids because the patient had used betamethasone cream. Once tinea corporis is manipulated with steroids, then the most appropriate word to use is called as a tinea incognito. It's called as a tinea incognito. So Shreyas, Shabit, Rahul, Vikas and Rajesh, so all of you are answering, out of which most of you are getting it right. The correct answer should be tinea incognito. In case you got the same video for your exam and there is no mention that betamethasone was used, then from here your spot diagnosis can be a tinea corporis, especially if the MCQ says that the patient is having a KOH which is going to be positive. Because in all the fungal infections, what happens? The KOH, the potassium hydroxide test, will be positive, right? So this is called as steroid modified tinea. Very good, Afsana. That is going to be steroid-modified tinea or tinea incognito. So let's move to the next question now. A 37-year-old woman presents with the facial pigmentation as shown in the video. The lesions are asymptomatic and more prominent after sun exposure. What is the treatment? So from the image itself, I'm sure that most of you have got the answer, but still, let me play this video. Now, this is how the patient is presenting to you. There's a 37-year-old patient, and you can see that there is a brownish hyperpigmented patch over the face, right? So when you see this brown hyperpigmented patch lesion over the face, over the nose. Now, what's the diagnosis here? The diagnosis here, let me go back to the MCQ. In the meanwhile, before we discuss this MCQ, can anybody tell me what is the diagnosis? The diagnosis here, you're very good, Shreyas. This should be melasma. This should be melasma. So melasma, usually what happens, it can develop because of photo damage. That is why after sun exposure. This can also occur because of hormonal issues like taking OC pills, right? Pregnancy or some endocrine diseases as well, right? Now the question here is, what is the treatment? Rahul says Kligman regime. Okay, Rahul. Now let's make this more complicated because you are very correct. Because what do you mean by a Kligman regime? So Kligman regime means it's going to be a combination. It's a combination of a retinoid along with a steroid and a hydroquinone. So a combination of retinoids plus steroid plus hydroquinone is going to be a Kligman regime. But see the MCQ now. Tretinoin is a retinoid. Mometasone is a steroid. And hydroquinone is also given. Now imagine you are going to split the Kligman regime into 3. And then all 3 are there in the MCQ. What would be your right answer? So in this MCQ, I can easily rule out clindamycin, right? But among tretinoin, mometasone, hydroquinone, in the chat box, can you tell me what could be the most effective drug among all these 3? I'm having the answer already. Chris, John, Afsana, Apocalypse, Shabit, Jonah, all of them are answering it as hydroquinone, because individually when you see, hydroquinone is going to be the drug of choice in melasma, right? It is going to be the drug of choice in melasma. It is not going to be retinoid or steroid. But if they ask you together, then this could be the best answer among all, because in case a Kligman regime is given, a combination of retinoid plus steroid plus hydroquinone should be the right answer. Yeah, topical tranexamic acid is also there, but among all the options, the most appropriate one should be a hydroquinone in this MCQ. Okay, Afsana? So now moving to the next one. A 4-year-old child presents with the lesions as shown in the video. The child had a low-grade fever 2 days before the onset of the rash. Which of the following is the most likely etiological agent? So let me play the video for you. So this is going to say that there is a child with some lesions, and this is a video. So what I can see here is in the face and the palms and all there, and even in the foot, right? The child has developed some multiple vesicular lesions. These vesicles must have ruptured by now. That is why you can see multiple erosions. And this is exactly how the child has presented to you, right? So when you see this video, what is the diagnosis that comes to you? But always when you see these kind of videos or whenever you see images in dermatology, try to describe, right? So it's a child with vesicular lesions over the face, over the palms, over the foot. And these vesicular lesions have ruptured now to form erosions. Now when you see this, okay, Dhanush. So now when you come back to the MCQ, what should be the diagnosis? पहले diagnosis बता दो, and then we see what is the etiological agent. Yeah, very good. So here all of you, as all of you are answering in the chat box, the diagnosis should be a hand, foot, mouth disease, right? So you're able to diagnose the hand, foot, mouth disease now. So from the hand, foot, mouth disease, now the question is, what is the most likely etiological agent? Is it a varicella zoster, Coxsackie virus A16, herpes simplex virus type 1, or human herpes virus 6? Yes. So now the correct answer should be a Coxsackie virus A16, which is the most common virus which causes hand, foot, mouth disease. Clinical elongated vesicles. Yeah, vesicles are usually small, but you can see that those all the entire vesicles were ruptured and all, but that's how the video has come, right? So now let's see the next one. Which of the following is least likely to be associated with the following condition? So in the condition, the video shows that a patient is having some lesions over, not this one. Yeah. The patient is having some velvety texture right over the neck region. The entire texture of the skin has changed and there is some hyperpigmentation. Can you notice those hyperpigmentation as well? So there is some hyperpigmentation along with some velvety texture over the neck region. So what is this? Yes. So now going back to the MCQ. First, what is this condition that you have seen? Velvety texture, hyperpigmentation. Together, do we have a name for this condition? A very good, Chris Johnson. So this is going to be, the diagnosis is going to be Acanthosis Nigricans. So here the diagnosis is going to be Acanthosis Nigricans. And the question here is, which of the following is least likely to be associated? Is it obesity, Addison's disease, PMOS, metabolic syndrome? Excellent, Rahul, Shabid, Zakovako, Shreyas, all of you. All of you are right. This is going to be Acanthosis nigricans. Now tell me, what is the least association? Least chances to be associated. Because among all the options, as all of you know, the most common association is going to be obesity, right? So other than obesity, PMOS, metabolic syndrome, all can be associated, but what is not associated is going to be Addison's disease. Not associated is going to be Addison's, right? All the other one can be associated, including malignancy, which can be a rare possibility, but still it can be associated. Clear? Very good. Most of you are getting it right. The answer is B. Now let's move to the next question. What is the most likely diagnosis? So they're just asking you for the diagnosis, and in the diagnosis, this is the video that is given. Probably it is a child, and you can see that there is some lesion over the forehead, and in the lesion over the forehead, this looks like a depressed lesion, atrophic lesion, and it is having a certain peculiar shape as well. So once the patient is having this kind of a lesion over the forehead, atrophic lesion, depressed lesion with a peculiar shape over the forehead, what could this be? So many of you are answering it as option B, that is Morphea. Very good. So let me just go back to the MCQ now. The options were linear lichen planus, Coup Sabre, discoid lupus erythematosus, alopecia areata. Easily not alopecia areata because you don't see a alopecia here, right? Out of all the three options, most of you have answered it as Coup Sabre. Now, what is this Coup Sabre? So this means there is a sword-like lesion, like there's a sword-like lesion, and this sword-like lesion, which can be seen in the forehead of this patient, this is associated with a linear morphea. It is associated with linear morphea. So what do you mean by a morphea? Morphea means it is going to be a type of scleroderma. It's a type of scleroderma. So whenever the skin becomes thickened, right, it's called as scleroderma. When there is no systemic features, we can call it as a localized scleroderma. And this kind of a localized scleroderma with a typical shape like that of a sword. So this is having a sword-like lesion, and this is called as Coup D. Sabre. Hair dye versus bindi dermatitis and chemical leukoderma, how to remember, easy trick. See, when we go to those kind of questions, hair dye means after applying the hair dye, the skin must have turned white in color, right? That is called as chemical leukoderma because of a hair dye. So यहाँ पे भी there is a hair, just underneath the hair there would be a whitish discoloration. And bindi dermatitis and bindi leukoderma, like after applying bindi, if the skin turns white, chemical leukoderma, right? After applying bindi, if the patient develops allergic rash, that's going to be bindi dermatitis. That's the easiest way. Yeah, you have to definitely take the history and you have to see what is the changes in the skin. The changes in the skin, if it is going to be turning white in color, leukoderma. If it is going to be eczema or allergic lesions, it should be a dermatitis, right? That's how you can reach out to the final diagnosis. Now moving to the next question. The nail finding shown in the video is classically associated with which of the following, right? So first, to understand this, let us see the video first. Now this is how the patient has presented to you. So once you examine the nails, you can see that there is some depression over the nails. The entire shape of the nails itself has changed. Now what is this kind of a nail called as? Yes, so this kind of a nail, I hope all of you have seen the video well, right? So if I go back to the MCQ now, they are asking you what is associated with such a nail finding. So before we write down about what is the association, first you should understand what is a nail finding, right? So what is a nail finding? This nail finding is called as Koilonychia. So this is called as Koilonychia. So Niveta, Afsana, Rahul, all of you are answering this as Koilonychia. And Koilonychia, the meaning is there is a spoon-shaped nails. So there is going to be a spoon-shaped nails in terms of Koilonychia, and the most common association of Koilonychia is going to be an iron deficiency anemia. I've answered it as iron deficiency because already in the chat box a lot of you have answered it. Spoon-shaped nails associated with iron deficiency anemia, and this is called as Koilonychia. Now moving to the last question of the day. Now this one, which of the following examination findings under the Woods lamp is most likely to be present in the condition shown in the video? So now we will see what is a condition first and then we will talk about the Woods lamp finding. Now you can see that the patient is having some deep pigmented lesions over the palms, over the hands as well as over the face, right? So when you can see these kind of deep pigmented lesions, a hypopigmentary or a deep pigmented lesions over the palms as well as the face, what is this? Okay, I'm getting the answer of the MCQ. पहले ये बताओ कि diagnosis क्या है? Like, can you be very specific here? Like, which type of vitiligo are we talking about? If you want, I can give you options. Is it an example of a focal vitiligo? Is it an example of a segmental vitiligo, an acrofacial vitiligo, or a vitiligo vulgaris, or vitiligo universalis? Very good. So here in this video, what you are able to see is a acrofacial vitiligo. So when we take an instrument which is called as a Woods lamp, and when you're going to turn on the Woods lamp over the diseased skin, so you're going to expect some colored fluorescence, right? So is it going to be orange red, chalky white, coral red, or yellow green? Yes, Chris Johnson, this is an example of a acrofacial vitiligo. Acrofacial means acral means extremities, facial means face. So when the extremities and the face they are involved, it's called as acrofacial vitiligo. Clear? And yes, here you will be getting a chalky white colored fluorescence. Right? You'll be able to see a chalky white fluorescence. And for your NEET PG exam, it's very important for you to learn all the Woods lamp examination findings. right? So when you get a orange colored fluorescence, especially in the urine, what is the answer? Orange colored fluorescence of the urine in a Woods lab examination. So what is that? Yeah, this can be seen in a condition called as Porphyria cutanea tarda. Can be seen in Porphyria cutanea tarda. And in the MCQ, where do you find a coral red fluorescence? Where do you see a coral red fluorescence? Yeah, coral red fluorescence can be seen in a condition called as erythrasma. Can be seen in a condition called as erythrasma, which is caused by Corynebacterium, right? And yellow color fluorescence or a blue or a green color fluorescence in the trunk especially, it can be seen Pityriasis versicolor. It can be seen in Pityriasis versicolor. Yeah, not rosea, it is Pityriasis versicolor. Okay, Tinea versicolor or Pityriasis versicolor. So all those Woods lab examination findings are also going to be very important in terms of your NEET PG exam. And Steven Johnson versus 10 overlap. I think Dhanush is answering to Zakovako. That is 10% is Steven Johnson and 30% is going to be toxic epidermal necrolysis. Done. So that is all about today's discussion about 10 video based questions. So this was our second session and we'll be coming up with more sessions like this in the coming days. Right. So thank you so much for being a very interactive crowd. And I hope there is no confusion in whatever we have discussed today. Right. So I'll see you again for the next session. Okay, thank you so much.